I'd like to, if I may, just ask a quick question of Sharon. Really moved and touched by your presentation, Sharon, but you said very quickly that you've been thinking about storing the rates for a long time, and I'm interested to know what that nugget of information that made you think that was, because I'm sensing a tension there with what Melanie was saying about the fact that people are not aware. So how come you were aware where many other people are not?
Good question. I think I'm very lucky in some of the circles of friends that I've got, and some of the people and the awareness that's been brought to me. Growing up, I'm still very close to my friends from school. 3 of them are nurses, 1 of them is a midwife, and I circulate with them occasionally. And I've also had friends who have experienced fertility problems. I'm the sort of person that wants to support a friend, and I will go into a lot of depth of finding out what they're going through, and therefore that kind of whet my appetite. I first actually started to look into it when I saw an advert on the tube with a nice little baby from one of the clinics in London saying, "Come and freeze your egg." And then that's where I started to get down a bit of a rabbit hole. And then as me and my best friend approached 30, she was diagnosed with breast cancer and went through egg freezing herself. I'd already done a lot of research around it and was able to support her, and it probably gave me a lot of strength in knowing how she had been brave going through the process for when I then did it a few years later.
Thank you. So, I mean, raising awareness and talking about it was actually part of it and personal experience. Melanie, a question for you, if I may. We heard passionately about how perhaps the 10-year storage limit should be altered. I actually agree with that, and I feel also passionate about that. But is there not a danger in so doing that we have the law of unintended other consequences happening? And what's in my mind is exposing the NHS to the management and the costs associated with pregnancy and delivery in women who are now older. Are we not encouraging a medical problem in doing that?
Another one of my interests, of course, I used to run an over 40s antenatal clinic. You would be amazed on how fit women are now. But no, of course, there's going to be a sensible limit, isn't there? That comes back to medical safety rather than the challenges of the law. I thought you would be more concerned about building up a bank that just grew and grew and grew and using NHS resources in that way.
We may come on to that, but not for now. James, Rachel, you both touched on this issue of extending 10 years for those that have premature infertility. How do we define premature infertility? Rachel, as a regulator, how do we define that? Can you hit the button?
The code of practice is very grey about this, and we do acknowledge that. It is a medical opinion to do so, so whether that's right for a regulator to completely define that, it would need the input from clinicians to come up with something. But that definitely is something that we are looking at because there is a grey area.
From your perspective, James, legally, having such a vague definition, how helpful is that?
Well, lawyers love uncertainty, so it's helpful to lawyers, but I can also see the challenge it poses to clinics in making sure that they comply with the requirements, because it would be helpful to have at least some greater guidance on it, but there's no definition in the statute or in the regulations.
There's a research project there for someone. Ladies and gentlemen, who has a question? Can we go to the back there, closest to Susan? Yep.
Hello.
Please introduce yourself.
Alison McTavish from Aberdeen.
What is your question, Alison?
Well, it's actually a comment to, sorry, I can stand up so I can see at the front, to Melanie, who alluded to some work that we're doing in Scotland, that I just wanted to highlight that through Scottish Government we've been working on a national pathway, and one of the things that we've done, we've had some funding, and we're looking at a liaison nurse, because we identified the similar position to yourself, that the oncology team are the ones that don't know about the issues. So rather than having all these people referred and ending up in the IVF centre, that we are putting in place a fertility preservation nurse specialist role, and hopefully we'll be able to report back in a couple of years how effective that is. But that's one of the things that we are doing here. Just a comment.
Not so much a question, a comment.
Not a comment.
Maybe there's a question here.
Yeah, it's Matt Tomlinson from Nottingham. I got a question related to your last point about premature fertility. And it was more about if you've got evidence in the patient records that his fertility has not ended and it has returned, he's perhaps had a baby naturally since his chemotherapy, is that storage then lawful, just because he's got an MPS form signed?
Ponder the answer to that, panel. Is there another question? Yes, the lady there with the hand, and then we'll go to the guy with the red jumper.
Hello, I'm Sharon Zara from Edinburgh. Premature infertility in men versus premature infertility in women. Are we going to have one age? Men don't become infertile, really?
Interesting point. Thank you. Can we go to the guy in the red jumper? And then we're going to go to the panel.
Hello, my name is Neil Maddox. I'm an academic lawyer. I just want to ask James, do you think there's a danger that, or rather a chance that the 10-year storage limit might be incompatible or be declared incompatible with Article 8 of the Convention? And just off the top of my head, two things seem vulnerable. The 10-year period seems
Can you
arbitrary.
hold the microphone up a little bit?
The 10-year period seems arbitrary because it's not fixed to anything like medical considerations or anything like that. And secondly, this distinction between medical infertility and non-medical kind of reasons for freezing eggs, I wonder, would that be seen as pursuing a legitimate aim? So it's a speculative question, but I'd be interested in your view.
So two comments about premature infertility. One about age, which I don't know if anybody wishes to pick that up, but someone certainly said that it wasn't an age-related definition, I thought. Yeah. Please, yeah, please do.
So, in relation to your first point about the convention, I think my personal view is that I think it would be a hard case. I think it's unquestionable that a court would recognise that the right was engaged. Whether they would be satisfied that the UK had gone too far in imposing a limit, I think, is a much harder argument. I haven't heard any clear rationale for the 10-year cut-off, but I imagine that in the event of litigation, a rationale would be produced, and it would have to be it would then have to be argued as to whether or not that was sufficient to justify the interference with the patient's rights. But I can see that being a difficult case. Not an impossible case, but a difficult case.
Rachel, would evidence in the notes from a regulator's perspective that a man or woman had had a child after they'd stored undermine a definition of they could claim premature infertility?
Bearing in mind I've only been in post 6 weeks, this is actually one of the questions that I discussed with Head of Legal this week, because it is too grey in the Code of Practice. And the question was exactly the same as that. If a gentleman has stored sperm, he then goes and has fertility, returns, goes on and has children naturally, is that still classified as a risk of premature infertility or infertility? And again, I know it's going back to what I said previously, but I think there is a need for some clarity around this. But it will involve work with British Fertility Society and medical opinion around that. It's not clear at the moment.
Melanie?
Well, I would have thought he's probably not planning to have chemotherapy again in the future. And so he has not got the risk of premature infertility. Of course, those men often then say to us, I'd still like those samples kept. It's happened to me once, it might happen again. But we don't continue storage.
Any more questions from the floor? Can we go to this lady at the back behind you, Susan? And then go to the front here, Sarah.
Thank you so much. Sorry, my name's Amy Cohen. I'm a trainee embryologist at the Frozen Fertility Centre. My question is really mainly to Sharon, but kind of picking up on what we were saying about awareness of egg freezing. So at the moment on my Facebook newsfeed and everywhere I look on my cookies is all about fertility freezing parties. So go along, have a glass of bubbly, talk about preserving your fertility. So, of course, this is raising awareness and letting me know about it, but how do we feel about this sort of marketing for something that actually, like you said, really is a medical procedure? And I just wondered what your thoughts were.
Hold that thought. Is there a question here somewhere? Yes.
Yeah, Christina Hickman from London. My question is for James and for Rachel. Given different countries around the world have chosen different ways to regulate fertility being such a fast-paced field, do you think that having it ingrained in law is the correct form of controlling this field?
So while you think about that, let's go to the bubbly. I think this was a story in the Daily Mail at the weekend. A clinic somewhere, I can't remember where, was having bubbly and canapes evenings to talk about egg freezing. What are your views on that, Sharon?
Well, it's the marketing as a whole in the multi-million-pound fertility industry that exists within the UK. I think it applies to everything to do with fertility, not just an egg freezing. I certainly saw that at the fertility conference with lots of companies from around the world, in fact, some of them saying, "We guarantee you a baby," which is a bit concerning. I think it's really important to raise awareness, and I think that seeing things come to light on social media is a positive thing in terms of the conversation is moving on. I myself am very open in talking about fertility, but I'm also very mindful that for other people when I'm speaking, it might not be an easy journey for them, or they might not want to talk about it themselves. And so even me, I find myself walking on eggshells sometimes in talking about it, so it's striking that balance. What I think about it in terms of bringing kind of awareness and raising awareness is we need to start much, much earlier in life. We need to start with education at the beginning. I was part of a generation that was targeted for teenage pregnancy, and no discussion around fertility and what it meant was really ever described to me. And I think that's kind of the shift that we need to start seeing in terms of education and people being aware of their bodies and aware of what happens as we get older and understand some of the implications on fertility. So that's what I think about it. I think in terms of fertility parties, they're not going to be for everybody, but for some people it might just open their eyes to something that might support them, so I don't think they should be stopped necessarily.
Melanie, as a clinician, I think you were quoted in that article, weren't you?
Yes. I'm afraid I gave a more negative view. I think talking to your friends over a glass of Prosecco, absolutely fine. Well, some of us do it. But I don't think it's an appropriate venue for a health professional to be talking about a serious medical procedure. It's not appropriate. And also, if somebody comes up to you with a glass of wine and canapes, they usually want something out of you. This is marketing, it's not medicine.
Thank you. Rachel, James, did we learn anything from other countries? I was struck when I was banking my own sperm, but also when I was working in that environment, that I could get a mortgage by filling out fewer forms than the forms that I had to fill out to bank my sperm. Can we learn anything from other countries? Can we make it easier?
I've been in the very privileged position of working in very many countries overseas and in different countries. And since I've been at the HFEA, it is amazing how many countries actually say we wish we did have regulation and we wish we really did have a framework to work around, not only from a limit to how long eggs and sperm can be in storage, because sometimes that's indefinite, but also from a trust perspective from the general public. And I think we have that in the UK, that's allowed, although it can be seen that sometimes having regulation can stop progression, we did allow mitochondrial donation, and it was accepted in society. And I think some of that is because of having that regulated framework which the general public can trust in. And certainly when I've gone overseas, they have looked at what we've done and wished they had a similar model. That doesn't say that it can't improve, and it is 30 years since the Act was obviously coming, and this type of medicine does move forward very quickly.
James, you must love the complexity as a lawyer, so could we make it simpler and easier?
Keeps me in a job. I think, as a regulatory model, if you're going to regulate IVF and embryo research, it's a good model. And I haven't seen another one elsewhere that I think is better. And as Rachel says, lots of other countries look to us as having the best or a very good model. And like mitochondrial donation, we've recently seen with genome editing, the difficulty that other countries have had in regulating that. We don't have that problem. It's really clear in the UK what you're allowed to do and what you're not allowed to do. I think if I have concerns, and this came up at the last Progress meeting I spoke at, it's with the weight or the burden of regulation for routine IVF and the paperwork, and that in turn leads to, in certain respects, the cost as well. And I don't really understand why IVF is regulated in the way that it is today. There are good reasons why it is, because that system was designed and developed in the 1980s. And it's certainly not the HFEA's fault that it's required to regulate in the way that it is, because that's the law we have. But I think there is a good case for saying that routine treatment shouldn't be singled out in the way that it is for quite unique regulation compared to other areas and arguably more controversial and more complex areas of healthcare. I don't like Prosecco, so I'm not going to talk about the other question.
Perhaps because you put ice in it from your freezer. Question there at the back.
Hi, thanks, Alan. Ruth Wild, I'm a fertility counsellor, and I ought to declare I'm an HFEA member too. This is a question for you, Sharon, actually. I came in halfway through your presentation, which was lovely to hear. And I imagine there's lots of people here from clinics in the audience. And I just heard how difficult it was for you, how difficult the whole experience was for you. And I was wondering if you could just concentrate your mind to find the top 3 things that clinics could do to make that more bearable. Thank you.
Think of the top 3 things, Sharon, whilst we just take another question, and then I'll come back to you. There was another hand up there. Yes.
I think it was Rachel who mentioned that so consent needs to be continuous. There must be no gap in consent. As a clinician, it feels very strange that the law is dictating something rather than the patient is dictating something, if you like. And I guess that one of your slides, one of your points was that most clinics don't have a way of finding out, for example, if the patient has died. But then there's the confidentiality dictated by the code of practice that fertility is not part of the normal hospital records. So the two don't go together. If you can't speak to the rest of the hospital system because it's secret, then how can you link the fact that the patient has died and therefore the donation should perhaps no longer be stored? So we need to clarify that.
There is obviously conflicts, and this is why, the Act is 30 years old and doesn't reflect how medicine works now in hospitals, for example, with electronic systems talking to each other. But you can actually find out through patient spine or accessing different systems whether a patient has passed away or not, and that can be done within a clinic, and it can be done without having to talk. But obviously if a patient is referred, you can speak to the person or the consultant that referred to them. So thinking of my other hat from where I was working before, we did have systems to be able to find that information out and do regular checks on that.
Can I just pick up briefly on a point you made, which is that I think it's almost a philosophical point, but you touch on the question of what the purpose and the role of consent is. And in this field, because it is so tightly regulated, it becomes a very legalistic issue of whether or not a form has been filled in and whether a box has been ticked. Whereas in other areas of medicine, It's really a far more organic process of dialogue and patient-specific discussion and information, and it can change and evolve over time. It can go broader or narrower, and it's about an enduring will, but a journey, you know, a linear process, whereas in IVF, we're very much about the form and the paper and the box. And there is a bit of a tension there between the way the courts deal with consent in other areas and the way that we are forced to deal with consent because of the way it's regulated in IVF. And the clinics have to, it's no mean feat, they have to comply with both. You know, they have to obtain valid consent to comply with the common law, but they also have to make sure that they fill in these wretched forms properly. And there is a tension there.
Can come in there to say how much I agree with that. I mean, when I was an obstetrician, which was before Montgomery, but, you know, I could perform very complicated manoeuvres in an emergency situation with minimal written consent, because you'd be running down the corridor with somebody bleeding. She understood what was going on. I knew she understood. You could proceed. And then I'd come downstairs with put the PR hat on, and you'd spend hours going through forms. You'd find that the patient had put his date of birth into the date box, or vice versa, and the whole thing was invalidated. That would be another hour of one's time going through it again. It was unbelievable.
Sharon, that should give you enough time to...
My top three.
Top three ways clinics can
I've gone for a before, during and after. So I think before, the information that's provided. The night before my egg freezing process, I wrote a blog, and I read it last night for the first time. And in it I wrote, I don't know what I'm doing tomorrow. I can't remember the symptoms for hyperstimulation. I can't remember whether the drugs I'm having are oral or whether they're injected, etc., etc. My consultation had been 10 months before, and all of the information had gone, and I didn't have anything that I was able to go back to. So I think something that's to take away, I think that would be really, really helpful for people to be able to refer back to. That's one. Two is support during. I mentioned it when I spoke. Having an emergency contact number is great, but it wasn't really emergencies I needed, but I really did need some support and some answers, and I think that would be a really good thing to improve. There was lots of support I had before in counselling I had before, so the journey is there, and let's just try and make it more fuller from end to end. And then finally, the aftercare. Having some sort of letter and maybe like some clarification that my eggs are in the freezer and it's plugged in and how many there are, and so that I'm not relying on my sedated memory and the piece of paper that I found at the back of my bag a week later on how many I got. So I think they're three steps that I think would just give a bit of a warm hug around it.
Thank you. Ladies and gentlemen, our time, according to my schedule, is almost up, but in the true spirit of PET, we usually have a roundup and a final set of thoughts for our panel, rather like Jerry Springer. So whilst you think about your final thoughts, I just wanted to say from my perspective how much I'd enjoyed this, and thank you for PET for putting this on. What I get from this is that this is so bamboozlingly complicated, it is surely time for review and reform. That's my conclusion, but I'd like to hear what the panel have to say. And we'll start at the other end. So if we could, Melanie, what is your final parting?
Besides agreeing with you, Allan, as I always would, my takeaway thought is that Scotland does this so well that I hope that in 5 years' time the rest of the UK will be following your pathway in terms of your service provision for medical fertility preservation.
My closing thought is that I hope that we've got a population in the UK that's going to make the change of the outdated law happen. I was told when I was making the decision, don't worry about the 10-year egg freezing rule, it'll be gone by the time you get there. It won't be if we don't have active voices, and so I really hope that with things like the Extend the Limit campaign that we can get some movement behind these changes that we're talking about that are outdated today.
Rachel.
That the HFEA is there to regulate the HFEA Act, and we acknowledge that there are complexities around that and errors can be made. And I think the discussions over this have really helped us to understand where those challenges are, and hopefully in the next year we can produce better guidance, better help and support. So with what we've got at the moment, we're going to reduce the pressures for patients and clinics so that consent is done more effectively and accurately.
James.
I'm not aware of any cogent or rational explanation for why the 10-year period was set where it is, why there is that cut-off. I hope that it will be revisited in relation to non-medical storage, and I hope that the requirements in relation to storage and consent in this area are reviewed wholesale and simplified as far as possible. And if you can, I would urge you to contribute and speak up in relation to Progress's campaign for this area to be reviewed and for there to be a proper debate in Parliament about how the law should evolve in relation to storage.
Thank you. Thank you, panel. You've been great. Thank you, audience. You've been great too.